Thank you. Our next speaker is Allison Lazard. Allison is an assistant professor in the School of Media and Journalism and an associate member of the Leinenberg Comprehensive Cancer Center at the University of North Carolina at Chapel Hill. Her research evolves around a core interest in how visual and interactive design influences the perception and impact of health messages. She collaborates with public health and medical experts, developing design strategies for complex communication topics, including tobacco control, cancer prevention, and cancer survivorship support. I welcome Dr. Lazard.
Hi, everyone. What a day, huh? So thanks so much for having me. I'm honored to be here and to share this with you. We've talked a lot about these really big initiatives and large strategies that would take a lot of resources to change. And what I want to do today is share with you some simple strategies that you could implement tomorrow in your work. Visual design strategies that might change the way that you understand what your patients or your audience are looking for in their designs, and ways to uncover kind of what they're currently thinking. So before I get started, I'd like to acknowledge all my collaborators. There's a few listed here and others at UNC and other institutions. And I'd also like to acknowledge that the views today are mine and my team's alone and not those of our funders. When we think about effective communication, especially designing effective communication, we need to think about our audiences first. We know this, right? We need to understand what they need and they want based on what they currently think, feel, and behave. And once we have an understanding of this, we can then turn to the objective designs. And here I have this laptop to represent where we would apply theory and evidence-based designs. We know what works, but we don't necessarily always know what works with what population, so we need to look at those two together and evaluating the subjective user experience. And that's where we kind of bring those two things together. Of course, this is an iterative cycle. We don't ever fully understand our population, and we don't ever fully understand the user experience, but we need to keep going through this cycle. And of course, this applies for apps, as we've talked about, as we move forward into a smartphone-saturated environment. 81% of Americans now have smartphones, and in younger populations, I think a lot about cancer prevention with adolescents and young adults. 95% of adolescents own or have access to a smartphone. So in an ideal world, we would have cancer messages, we would design them well, and then our audiences would engage with them. And they would think and feel and behave in the ways that we intend. But it doesn't really work like that, does it? And so we know, though, that there are certain things that we can look to improve this process. And we have decades of research and evidence that shows there are some key factors that will help this process. As other people have mentioned today, if messages are relevant, if we can see ourselves in a message, or we can see something about it being relevant to our situation, we're going to be more likely to engage with it. And if we think it's useful, if there's something in there that's going to help me be a better person, to live a healthier life, or just enjoy my day, then I might be more willing to engage. And the third thing here, represented by this laptop with the stopwatch in it, is design. In the first few milliseconds, we evaluate online health information as good or bad. It doesn't even take a second to do that. So that's not enough time to read all those words and determine if that's a valuable argument or not. We're judging it by the design, how information looks. And we've done this because we have years of experience of dealing with various health messages. We have expectations of what they should look like. So when people find out that my area of research is visual communication, generally within a few minutes I get the question, well, what design should I use for my project? That's a really hard question to answer. And if I point you to the literature, it's not a whole lot easier. It's often the advice is use an engaging design. Well, that tells us about the end goal. It tells us nothing about the objective properties that we should use or the principles or strategies we should use to be designing messages that our audiences will identify with. So what I want to do today is give you 5 methods and strategies that you could implement to design messages with your organization or to think about putting into your research to really kind of put our patient populations first. So the first is selecting relevant messages. I'm going to give you a process for selecting relevant messages because not any one image would ever work in all context. So recently, our team investigated how the FDA could best communicate about harmful and potentially harmful chemicals, and cigarette smoke. This isn't something easy to communicate with the public, which is the goal. But early on in our process, we decided we needed to have icons that would represent some of the health harms that we were going to communicate, cancer caused by smoking being one of them. So our team deliberated, and we went through rounds of revisions, as many of your teams probably do as you're developing messages. Which image should we use? And we came up with these 3 icons as our potential options for cancer caused by smoking. But we got no consensus among us, and we were at a stalemate. So at this point, it's generally time to stop our small group discussions and turn to our audiences to ask them what they want in an image. So we did just that. We took the traditional social science approach, and we asked people a battery of questions about these icons and others. We asked how it might feel, how it might influence their thinking about smoking, or how they felt about smoking if they saw these icons. But we also just asked them a single item. We said, choose the icon that is most resonant with you. And what we found is, notably, when we asked a battery of questions and a single item, we got the same finding and the same effect size. So we learned quickly that instead of asking people a lot of questions, we could ask them a very simple question because they can very easily respond. Also, we learned that if we leverage the power of crowds, we were looking at a general public audience, so we used a convenient sample of 700 US adults, and we were able to get to a very clear answer. The big C on the tombstone was selected by more than 60% of our participants as their preferred icon. It wasn't my preferred icon, but that was the same as that we found with the other measures that we asked in a much more taxing way. The next step in this particular project was to communicate the amounts of these chemicals in cigarette smoke. Now, this is an even harder challenge. We were going to do this on a website. As you see here on the left, this is our website that we developed. But this is really hard because most Americans are unfamiliar with what chemicals are in cigarette smoke. And even if they knew about the chemicals, a lot of times they're represented in units that make no sense, nanograms, micrograms. It'd be hard for many of us to make decisions based on this information. So we developed 2 versions of this. So yes, I have the call-out boxes over here on the right. So in the top version, we represented the quantities as they actually are, represented in nanograms and micrograms. And then in this bottom version, we replaced those with qualitative information, giving contextual meaning to this. These were easier to process cues. Most of us are familiar with a stoplight, like our timer up here, that we know that green means go and red means stop. Notice there is no yellow here, because sometimes that means go faster. So we have green for safe, we have light red for risky, and we have the darker red for the most dangerous, to communicate at a glance kind of what the amounts of these chemicals mean. And what we found is when we asked a nationally representative sample of US adolescents and adults is giving them the information in this way, although it is less medically precise, they thought it was more useful. And they also thought they would use the website more, and it discouraged them more from smoking. So even though it was a trade-off, and our toxicologist was very hesitant to agree to this scale, it was worth it to be something that's easier to process and interpretable to our audience. We've been talking a lot about what's on social media and how we're exposed to a variety of messages. We live in a media-saturated environment. Our audiences are often looking to the design to guide them to the most important information. So we enlisted some adolescents and young adults to help us develop an online resource about risk of non-cigarette tobacco products. And after talking with them, we developed 3 different ways that we could use cues for visual hierarchy, or ways we could use the design to guide readers to what's the most important information. So our adolescents and young adults told us they want concise, novel facts. So we created those, and we put them in the largest font. And this is a mobile-first site that is a series of single-scroll pages that could be viewed on a phone or a desktop. And we put those concise facts at the top in the large font, so as soon as you get there, you know that's the most important information. We also added redundant visuals. Our adolescents and young adults told us they want to skim. They want to skim, and then when they see something of interest, they'll take a deeper dive. They don't want to have to look through everything. So having redundant visuals allowed them to easily identify information that might be important to them. We also use color intuitively. When there's a color shift, that means there's new information. So if they weren't interested in a topic, they could keep scrolling till they got to a new color, and maybe that would be relevant to them. Social presence. If we have social presence, it increases the warmth we feel in a communication, our sense of community, and also our engagement. Social presence is largely that feeling of being with others. In the absence of face-to-face communication, which we've talked about how wonderful that is, although we don't have a lot of resources for it, in mediated communication, we can look to design cues to elicit that feeling of being with others. We can have evidence of activity, such as indication that there's people using a chat room, there's ratings, other things like this. We can have interpersonal text where we get messages that are clearly from someone, or we can just have human imagery or avatars. And more than just a warm, fuzzy feeling, these increase attention, trustworthiness of the information, and the perceived usefulness, all key ingredients for effective communication. So recently, we wanted to evaluate if we could elicit more social presence with an intervention tool. We talked earlier about patient-reported outcomes. We're always trying to get better data from our patients and participants in our study. And so we have this intervention tool where we ask simple questions, and then as they go along, they get tailored feedback. You're looking at a slice of the nutrition information from this. And so we decided, what if we put some extra cues in there that there's people on the other side? And on the left version, we added cues for your community. We showed people doing the recommended behaviors. We said the tips and strategies were written for people like you. We gave social media sharing options. And in the one on the right, we tailored that to be from a particular source. So here you see that it's from a single physician. The tips and strategies were written in first person, and you can identify who that information is coming from. And what we found is both of them, compared to a condition without these cues, elicited that feeling of someone's on the other side. And these both led to increased perceived usefulness of the information, as well as intention to use the tool. So having that sense that there's an individual or a community involved in the communication is important for us to want to invest our time in it. Lastly, we need to understand where our audience is getting their mental models or mental associations and expectations of what information should look like. So to do this, we asked people to draw a health app for us without giving them a whole lot of information. And before I show you what they drew, I want to tell you what they said. So we asked young adults to do this. And we heard a lot of this. I really like simple interfaces that are clean looking. Yeah, I like that. I think a minimalist approach would be good. We heard consistently a lot of clean and simple. And when we're thinking about health literacy and limited health literacy, a lot of times that's what we're talking about. We're talking about clear communication, right? And that people want less so they can focus on what's important. Yet here's what they drew. I don't see a whole lot of limited functionality there, or here, or here. And so what we have is a mismatch between what people say they want. They want clean design because that's a buzzword and it's easy to say. But when we ask them to draw what they want these apps to actually look like and function, they're very complex and all the bells and whistles that they put into it. And so we dove a little bit deeper on where these perceptions are coming from. What we found surprised us a little bit. One of the most popular basis for a health app are social media. Popular social media such as Instagram serve as the basis of what people expect for communication with health. They're not health related though. Informational apps, weather apps were consistently mentioned. Did anyone check their weather app this morning? I did. And people look to these. That's where we get information in a clear and concise way. And so they want that, again, to be translated into the functionality of their health app. And perhaps our most surprising opinion was the Chick-fil-A app. That one had us stumped. We didn't expect that. But while people did mention various Fitbits and other nutritional apps that you would expect them to mention when they were talking about what they used as the basis of their model for a health app, it was by no means the dominant resource or the only resource. And so what this says to us is that we have to be careful not to get too siloed into our communication efforts. Our audience might not think about health and cancer messages in the same way we do. They don't have the same institutional norms that we do, that we think about our variety of what we're communicating. So pulling this all together, I encourage everyone to think about how they can use simple choices, asking their audience to make decisions and other ways that you can have them, just a simple question or two will help you select images that are resonate with them. How can we present data so it's interpretable at a glance, even if that might mean we have a trade-off of medical precision? How can we use cues or visual hierarchy to guide our attention in our very limited environment where we have limited attention? Also, what social context can we give people beyond the facts that will help them want to engage with information? And lastly, we just need to understand where our audience's expectations are coming from, their full media landscape, not just what we think of as health communication. That concludes my presentation, and I look forward to questions later. Thank you.